Good afternoon, all. Welcome to the Anti-VEGF Masterclass instruction course on precision, durability, and beyond. I would like to invite onto stage our panelists and co-instructors, Dr. A. Giridhar sir, Dr. Ashok Natraj sir, and Dr. Naresh Babu sir will be taking up as for the keynote lecture. He'll be joining in shortly. And Dr. Mahesh Gopalakrishnan sir will be coming in also from after another session. So this masterclass is just a short overview into the various aspects of the newer anti-VEGF treatments and the clinical aspect of using these molecules in real practice. It's not there, right? So we'll start off. So I'll be starting off with the newer anti-VEGF topic on anti-VEGF agents. So the dark ages before the anti-VEGF came into practice, 90% of our patients were undergoing going legally blind within 2 years of diagnosis, losing out 3 to 4 layers, lines of vision every year, and the final visual acuity being nothing more than 2200. So all we were managing were complications and not treating the basic underlying disease. When VEGF hypothesis came into play and it became a reality after the landmark trial by Napoleon Ferreira in 1989, pegaptinib came into picture in the first part of the this millennium in around 2004, which was the first approved anti-VEGF agent. And for the first time, we were improving vision and not only just treating the complications. And actually, we saw improving vision, and there was no visual loss as such. Then came in generation one with the prodigal son, as we call it, ranibizumab, and the underdog, that is bevacizumab, which came in to rule the roost for the next 10 years or so. So with the landmark trials like Marina and Anchor, they were found to have around 7 to 8 letters gains, almost 11 letter gains in 1 year time during the course of the treatment, and Rise and Ride expanded the horizon of treatment onto diabetic macular edema. The generation 2 came in the role of extended durability with aflibercept, with View 1 and View 2 offering the same kind of results as what Marina and Anchor had done for ranibizumab. But the only limitation with this drug was that about 50% of patients required less than 8 weekly intervals, although the clinical impact of the drug was such that it was an extended interval approval, but only about 50% of the patients were being able to manage at more than 8-week treatment gap. So Vivid and Vista provided the same kind of details about aflibercept in DME, what Rise and Ride did for ranibizumab, and then on and so forth. Anti-VEGF became the standard of care across various indications like AMD, DME, and vein occlusions alike. Then came in what we would like to probably call something like the generation 2.5, in which incremental gains became very important. So in 2019, it's almost like 6 years when this molecule had come into view, that is brolucizumab, which was the smallest anti-VEGF till date. The Hawk and Harrier showed that around 56% of the patients maintained 12 weekly interval treatments. But the only problem with this molecule was a critical safety concern which came with it was the intraocular inflammation to a humongous amount of 4.4% and 2.1% chance of retinal vasculitis, and it even today comes with a black box warning, which has limited its use very significantly. The another one molecule which came in 2022 was faricimab, which was a bispecific antibody having a dual mechanism of action of inhibition of Ang2 as well as VEGF-A. Again, was on paper theoretically very good, but only even in the randomized controlled trials, it was found that only 45% achieved a Q16 week dosing. And about 55% still needed more frequent injection. So we are there, but yet not there almost. So then reality check. The victories we've had is that the legal blindness rate has come down from 90% to less than 10%. The mean visual acuity gains have come to a respectable 6 to 8 letters. And anti-VEGF till date happens to be the global standard of care. Now, what is the unresolved crisis? It is that the real world experience shows that under treatment is there. Suboptimal response is seen in almost 15 to 40% of patients, and about a 50% dropout is there by year 2, and which increases all the way till 70% by the year 5. So why did we hit a ceiling? Probably the answer which has been put against it is probably that it's the vitreous barrier which causes a rapid clearance of the drug. We have been only looking at the VEGF-centric paradigm. We have not looked at anything else. And probably tachyphylaxis, which is seen in around 10 to 20% of patients. So what else do we have? After the first two generations, what do we have more? Next in line is something what are known as high-dose formulations, sustained delivery options, tyrosine kinase inhibitors, and probably gene therapy also. So high-dose aflibercept 8 milligrams, that is the next thing which is around the corner for at least India in the next year or so, which is anticipated. It's said to have a 4 times higher molar dose as compared to the 2 milligram aflibercept, which is currently available with us. And according to the Pulsar trials, it is said that more than 90% of the patients tend to maintain more than 12 weekly interval treatment. And the improvement was, they say the gains were non-inferior to 2 milligram aflibercept. Then came in Susvimo. Susvimo, although it was recalled back and now it is coming back into play, this is a surgically implanted device which acts as a reservoir for implanting. The one which is coming with it is ranibizumab, but it can be used for any other drug, potentially so, for use as a sustained drug delivery model. And the port delivery system requires some OR access and surgeon training for the specific, the amount of the surgical step which is incorporated into it. And the risk which is included with it is probably conjunctival erosion, and the risk of infection and vitreous hemorrhage is always going to be there because of that potential site from where the infection can enter. Gene therapy is probably one and a done treatment. Some molecules like RGX13, 314, ADVM022 and 4D150 are in the current phase 1 and 2. And the critical unknowns which are there is whether we do not do the long-term safety. It's only on theoretically and on animal models these have shown promise. But then immune responses, irreversibility, as well as the cost is the limiting factor. So one important mention here is biosimilars. Although they are nothing new, they are the same molecule, but then it is at a reduced cost. Innovation just isn't new molecules, it's just making the existing therapies accessible to all patients who need them. And the treatment burden challenge, if you look at it, it is significant. So looking at that, we need a paradigm shift in the treatment protocol. That is where in the tyrosine kinase inhibitors come in. If we are looking at it, initially we were looking only at the external moieties of the VEGF receptors. Now if we go into the second messenger level, it is the tyrosine kinase, which from wherein the endogenous cascade starts. And if we how this works differently, it is going to attack only the intracellular domain. So theoretically, again, it is going to be additional to the anti-VEGF molecule and can have some synergistic mechanism there as well. Oral and topical formulations had been tried, but then oral did not show very significant responses, and they had some hepatotoxicity and GI side effects along with it. Topical formulations altogether were stopped because all of them required some or the other form of rescue therapy, so they were stopped altogether. These are the other ongoing phase 1 and phase 2 trials which have been recently published in one of the retinal physician journals. And suprachoroidal delivery with this is again a potentially viable option, which is going to give something like, as of now in the phase 1 results, it has shown an 81% reduction in the treatment burden. So the future shows promising safety profile, reduced treatment burden, and a multi-pathway targeting from wherein we can start at least reducing the potential drawbacks which we have with the current treatment scenario. Thank you. So after this, I'll be calling upon Dr. Mahesh Gopalakrishnan sir for his talk on tackling anti-VEGF resistance and non-responders in neovascular AMD.
Thank you, Dr. Jyoti. This is a very important talk because when Jyoti gave me this talk, I started reading and I found that I didn't know a lot of things. What is resistance and what is non-responders and all this stuff. So I will go back to that. We have a good number of therapeutic armamentarium starting from Avastin to Vabysmo over the last 15 years, 20 years. And the problem is all the drugs will not work for every person. And a subset of patients respond very poorly to some drugs and they don't respond to some other drugs better. It is there in 20 to 40% in neovascular AMD and 15-20% diabetic retinopathy. So it is what is resistance to anti-VEGF? It may be a poor visual response. In spite of you giving, patient is not improving in vision less than 5 letters of improvement. And it may be a poor anatomic response, OCT. The biomarkers, they are not improving. But there are no recognized definition for this. So, there is a biological basis for this resistance. Why? Because the VEGF is not the only factor that can cause resistance. There are other pathways, PDGF, angiopoietin, a lot of other inflammation. All these pathways are there. That is why when you give some injections, it is not responding. So I took this article, How to Judge Failure, Defining Treatment Resistance to Anti-VEGF, a systematic scoping review. They took all the 400 studies and the 88 studies which met the criteria were taken. And in neovascular AMD, since this is on neovascular AMD, one mistake that many people make while telling it is resistance is due to wrong diagnosis. Some may be CSR, some may be PCN, some may be PCV, and some may be wet AMD. So the wrong diagnosis is one of the cause for so-called resistance, and various masquerades can cause resistance. Then duration of intensive prior treatment is very important. You can't give one injection and after that there is no improvement, say this is resistant to that. Okay, so the consensus based on this study was that the duration of intensive prior treatment required to define resistance was at least 6 months. Different studies showed 12 months, 8 months, like that. But at least there should be a 6 months gap, 6 months of intensive treatment with at least 4 injections in 6 months. Then only you can call it resistance. Then the biomarkers in OCT like subretinal fluid, intraretinal fluid, and some cases they used the PED and SHRM, which were also used. And some studies used visual acuity guidelines, less than 5-letter improvement over 6 months. So the criteria for defining treatment resistant neovascular AMD is 1, presence of SRF and or IRF in OCT. You can use worsening PED and other things also. Despite regular therapy, less than 6 weekly injections for over 6 months. That means at least 4 injections in 6 months. Although intensity of monthly dosing regimen has been used in many studies, a significant lot of studies they didn't have this 6-month duration to define resistance. Just one slide on DME, because we are all treating DME. There are 2 other factors in DME, because DME has inflammation as a pathology, and they use something called central macular thickness for defining resistance. So in DME, the resistance is if the central macular thickness is more than 300 microns or less than 10% reduction in CMT despite minimum 3 anti-VEGF injection. That is resistance in DME. Okay, so these 2 definitions you should be very careful. You should know. So 6 months. DME, you can call it resistance after 3 injections for 4 months. Okay. Neovascular AMD, you call it resistance if you have at least 4 injections in 6 months. What are the mechanisms? Different types of mechanisms are there. Alternative angiogenic pathways, receptor desensitization, even systemic problems. So you can predict anti-VEGF resistance based on imaging biomarkers like PED, intraretinal fluid, hyperreflective dots, ELM integrity, all these things. And molecular biomarkers are used, especially cytokine signatures, which are being used in different research. Predicting anti-VEGF resistance based on genetic and epigenetic predictors is another complicated issue. I don't know anything about this. But systemic and metabolic biomarkers like HbA1c variability and serum albumin and renal function are important in many cases, where especially in diabetic macular edema. So this is predict biomarker, OCT, inflammatory, angiogenic, genetic, and metabolic. So these are the things that predict anti-VEGF resistance. So like this, this is a case. Injection was given, 9 injections over 6 weeks interval. Then it was changed to aflibercept, 12 aflibercept, 8 weekly interval. Then it was changed to faricimab. In spite of faricimab, it was worsening continuously. You can see in spite of injections. And then after 5-6 weekly intervals of faricimab, it was converted back to aflibercept. This is a real resistant cases after 14. So what do you do when you inject and there is no effect? You have to change the dosing. You can shorten the treatment interval to 2 weeks, which is very difficult. As such, we are trying to reduce the injection. Now you inject every 2 weeks is going to be very difficult. So the second one is use higher dose. This is coming with aflibercept high dose. It's coming. So that may be a good option for NAMD. Then switching the anti-VEGF agent is definitely an option, especially some of the ANG2 or PAGF in aflibercept. So switching the drug using another pathway will help in many cases. Treatment option 3 is one that we use many times, laser or steroid injections in some cases, focal laser, photodynamic therapy. These things can work in many cases. So this is a case of PCV, not neovascular AMD. So this is after 3 injections, nothing is happening. Then this is a bunch of polyp and forced full fluence VDT in 2015. It became flat. To some extent, it stayed for 2 years and it again came back. And there were new bunches of polyps. And again, VDT was repeated. Again, after 2 years, it started coming back again. So we are not telling that it is going to end the story, but definitely the number of injections can be reduced. So key takeaways are shortening the treatment interval, not very useful. Increasing anti-VEGF dose, maybe. Switching anti-VEGF agent, definitely. And combining with the other therapies like laser and some drops. So what is the future? Tailored therapy is the future, where if the patient's inflammatory profile and fluid analysis may be done along with the initial listing, and some of them will have preference of some VEGF pathway or ANG2 pathway or something. And later, probably some patient may be ideal candidate for PDS or gene therapy. So these are the things that I just want to highlight about anti-VEGF resistance and management. Thank you.
Thank you, sir. Thank you,
Any
sir.
question?
Any questions from the audience?
I have to, yeah.
Actually, very good presentation. What I would like to add is that in patients not responding to anti-VEGF, I think there is a role for wide field ICG angiography, because many of these patients have got vortex vein abnormalities. And that is the reason why the VEGF is not acting. So there is still a role, because today we are managing all patients with OCT. So there is still a role for these sort of investigations in certain specific cases. And that should be kept in mind.
Absolutely. Not only wide field angiogram, FFA ICG has a role, because many times you will see a feeder vessel or a small polyp or something like that, which will help to give focal laser to that, which will totally then anti-VEGF injection may not be required. So even angio ICG and wide field are very useful in the multimodal imaging in neovascular IMD treatment.
Yeah, I heard of antibiotic resistance. The first time I'm hearing about it. We never thought. Good presentation. These are protein molecules.
It's a protein.
Protein molecule. So naturally the body will produce antibodies for it. So switching is one option. Giving adding steroid may be another option to suppress the. But the point here, if once it gets resistance, the more the same drug you give, there will be more inflammation. Because again, the antibody. That is why you see those spikes still, the fluid collecting there. Yeah.
Right.
Hearing rights.
So thank you, sir, for the nice presentation, sir. Sir will be leaving for one of the general body, election commission meetings. Now I'll be inviting Dr. Ashok Nataraj, sir, for his talk on optimizing anti-VEGF therapy in DME and NVAMD.
Thank you, Jyoti, for the opportunity. Now, after hearing this topic, then only I realized what do you mean by optimizing anti-VEGF therapy? It's a very strange term. Then only I found that, the ideal treatment for DME as well as wet AMD is give monthly injections. Keep on giving monthly injections. They all do well. Now, how do you reduce this monthly injections? You have any alternate strategies to reduce this monthly injections and make the number of injections less, but at the same time, keeping the response as good as giving monthly injections. So that is the main aim of this topic. How do you go about it? So the most important strategy to reduce the number of injections is early and prompt diagnosis. It doesn't mean that the vision is 6:6, you have wet AMD, you will wait for the vision to drop to 6:36, only then you will treat. No. Early and prompt diagnosis and early treatment. Okay, that is the most important thing. Now, the studies have shown that if you start treating after 21 weeks and if you treat at 7 weeks, there is 2.6 times of worse visual outcome in these cases. So this time is very, very important. And the treatment is in two parts. One is the early intensive phase. That is, you keep on giving monthly injections. That is something called as the loading dose. 1 injection, 2 injection, 3 injection, till the lesion becomes quiescent. So it's not that, it's 3 injections. It is number of injections. Every month you keep on injecting till the lesion is quiet. And interval between injections should be 4 weeks or less. So studies have shown that if the interval is more than 5 weeks, the patient might need twice as many injections as when it is less than 4 weeks. So that is a very important point. Now, this is one patient who has got wet AMD. We are starting the intensive phase. First injection you gave, it has become okay. You have given the second injection. Now it has become perfectly okay. The disease is quiescent. Now, one option here you have is you don't have to give the 3 injection. You start to extend the treatment at this stage only. And you can extend, instead of giving it 1 month, you can give it at 1.5 months or extend it by 4 weeks, 2 months and go ahead. So intense phase, don't keep in your mind that it is 3 injections. It is as many injections as is required to make the lesion quiescent. Now, after the intense phase, when the lesion has become quiescent, how do you go forward? Now, monthly dosing is ideal. You don't want to do that. The next best option is treat and extend. And the least preferred is PRN. But unfortunately, in our setting, you can only give PRN. PRN means the disease is quiescent. You keep on following up the patient every month. When the disease comes back, you give the injection. Again, wait. Treat and extend is like you give an injection, the disease becomes quiescent, then you extend the treatment interval by 2 weeks. You keep on injecting till 3 weeks, till the disease is perfectly okay, and then you can stop the injection. If the disease recurs, you bring back the interval between the dosing again less by 2 weeks so that more frequent injections can be given. Now, the advantage of treat and extend is all these studies, TREX, TREN, can treat. They have said that, treat and extend is as good as monthly dosing with lesser number of injections. Now, we can even tailor the treat and extend lesion. It's not that fluid should not be there to extend. Some amount of fluid can be tolerated. Like in fluid study, you can tolerate 100 micrometer of fluid. Aries trial, you can tolerate 50 microns. And keeping some fluid is actually giving some help to the RPE. And that causes foveal atrophy, and that prevents foveal atrophy and long-term side effects of anti-VEGF agents. Another thing is you can extend by more than 2 weeks. In the Altair study, they have extended by 4 weeks. So up to 16 weeks you can extend and then stop the treatment. Now, PRN in the CAT trial, PRN was considered as good as fixed dosing in the CAT trial, but no other studies have proven that PRN is good. It is always supposed to be inferior to treat and extend. Now, I'll just show you a case. This is one patient who came with wet AMD. Now, you're given loading dose of Eylea. First dose, it's become less. Second dose, okay. And after that, you're going to extend. So, you gave the next dose at 1.5 months or 2 months. Patient is okay. Then you're waiting. The lesion is slowly coming back. Some amount of fluid you're seeing there. Vision is maintained. Now you can safely wait. It is kind of a modified form of treat and extend. You don't have to go and jump and inject once you have small fluid. Now again, you wait, you give an injection, the fluid is gone, patient is okay. Again, the fluid is coming back. Again, you wait, tolerate some amount of fluid. Again, tolerate some amount of fluid, but the fluid is becoming more, vision is becoming less. Again, you inject, and now the lesion has become quiescent. So initially we started with Eylea, patient could not afford Eylea, now patient is on Razumab. Then again, fluid has come back. Now you go with Vabysmo, patient has got some insurance. Now after one Vabysmo, patient is okay. Then patient prefers PRN. He doesn't want to do treat and extend anymore. You follow up the patient and the patient is okay. So in real life, it is not treat and extend or PRN or fixed dosing. It's like, it depends on the mood of the patient and the mood of the doctor. Okay. So that is how optimization of anti-VEGF therapy happens in real life. Now the choice of drug, ranibizumab is there, aflibercept is there, and depending on patient economic, affordability and the kind of disease-free interval you want, you can decide on the kind of drug. Now, no activity is required, no activity is seen, futile to continue treatment, one night, all these factors, it decides whether you want to continue treatment or not. So these are the learning points: flexible dosing regime depending on the patient, modified treat and extend, improvement of regular follow-up, new molecules, and something called as observe and plan. See, observe and plan means when you have treating a patient for a long time, you know when the disease is going to recur. So if it is 3 months, it's okay. You come after 3 months, disease is recurred, give another injection. So that can also reduce the number of hospital visits. So these are the things. Now we'll come to DME. Now in DME, one thing that is different is you can tolerate some amount of fluid, edema, etc. But in AMD you cannot, because the vision really goes down fast and it is very difficult to retrieve whatever vision is lost. Now these are the DME patterns. So this is the basis. For central, we are only going to talk about central involving DME. So in central involving DME, the treatment of choice is intravitreal anti-VEGF agents. So we have the protocol I, where ranibizumab was given monthly as 3 loading doses and then as PRN. So you see the difference on treatment between AMD and DME. So DME, the established treatment is loading dose, PRN. In AMD, it is monthly fixed dosing all throughout the time. So that shows, DME tolerates some amount of fluid and, vision doesn't falls down really fast. Now, the good point about intravitreal injection is, see, as the time goes, the number of injection that is required to maintain vision becomes less and less and less. So that is one good news. And second thing is adding laser to injection. Does it really, lessen the number of injections? You see, prompt laser, deferred laser. The number of injections become less only by 1. So that is not much of a difference. So adding laser to injection is not going to affect the outcome in that much of, it is not going to optimize anti-VEGF therapy. So learning point is number of injections needed decreases with time. Combining with laser does not give much benefit. Visual gains did not differ. Visual at 5 years, proportion of patients with more than 15 letter improvement was more in deferred laser group. So adding laser is not really going to benefit in DME. So there are certain strange things that are there in DME because DME with good vision, you can even observe. It's not like in AMD. Now, in protocol T, when patients with worse vision, aflibercept may give better visual gains at 1 year, but at 2 years, it is almost the same. So, This is one patient with DME, good sugar control, you find the DME is gone. So that doesn't happen with wet AMD. It's totally different. So optimization of anti-VEGF therapy in DME is really crazy. It doesn't follow any rules, it depends on you. And wrong diagnosis is a patient with moderate NPDR in one eye. And you can see a T-cap, telangiectatic capillary here. No anti-VEGF works, focal laser, the disease is gone. That is something that happens only in DME. And this is a cyst, it has spontaneously regressed, happens in DME, no anti-VEGF. So these are some of, and you have this DME biomarkers which show chronicity, and that decides what anti-VEGF or steroids you have to give. So that also helps. Another thing is there is a mechanical factor called VMT. So when you have a VMT, anti-VEGF may not work and you have to think of other factors. So these are some of the points I would like to highlight. In DME, the basic difference in optimizing anti-VEGF therapy in DME and AMD. So this is one patient who had DME, FIPED or flat irregular PED, and shows a polyp, focal laser, anti-VEGF. It's a combination of DME and wet AMD. So to conclude, like optimization in AMD, it has to be more, you have to be more careful. Intensive therapy is required, regular follow-up, loading dose, treat and extend. But in DME, loading dose, PRN is okay. And you may try alternative strategies like observation, good diabetic control. Thank you.
Thank you, sir. Thank you for that extensive talk. Thank you very much. I'd like to call upon Dr. A. Giridhar, sir, for his talk on management of MNV in pachychoroid disease in the anti-VEGF era.
Thank you, Jyoti, for having me here this morning. So I'll be talking about pachychoroid disease, macular neovascularization in pachychoroid disease, and this is very important because this forms a substantial portion of our patients in a neovascular AMD clinic. So before we go into the actual talk, we have to understand what are the various phenotypes and presentations. So pachychoroid per se is not a disease, but pachychoroid epitheliopathy is a disease. And what we are going to talk about is a nascent or a non-exudative pachychoroid neovascularization, and the type 1 macular neovascularization, and CSCR with macular neovascularization, and PCV. So these are the four entities which we are going to talk about. And before we start that, I thought I'll just educate some of you about what exactly is pachychoroid disease. So this is a classic case of a pachychoroid disease from one of my patients, where you can see these sort of small, extensive RP abnormalities. These are not truly drusenoid, but these are basically RP abnormalities which you see in both the eyes. And when you do the OCT, you see these sort of changes. One is a significant increase in the choroid, significant increase in the hallux layer, and there is a compression of the inner choroid, and you can see the retinal pigment epithelium abnormality. So this is classic pachychoroid disease for you. And here you can see the large vessel here and causing RP atrophy and outer retinal atrophy also. So these are all classic features of pachychoroid disease. And when you do an ICGA, you see that the watershed zone in the center is lost. You have these dilated veins right in the center of the macula. These are all classic features of pachychoroid disease, which you see in many patients presenting with central serous chorioretinopathy. With this background, we go on to our cases. This is the first case I want to show you. You see the left eye has got a vision of 6/45. The right eye has got a vision of 6/6. And when you see the left eye, he's got a classic chronic central serous chorioretinopathy. He's got a very thick choroid, and he's got these cystoid changes. The visual acuity outcome is quite poor. But when you see the fellow eye, he's got again a pachychoroid disease, and he's got this classic RP abnormality, which is very, very important. And when you do the octa, you see the silent macular neovascularization. When you do octa, you have to segment it. Manual segmentation is very important so that you're able to see this particular area in the octa to detect this abnormal neovascular network. Therefore, this patient was followed up regularly. And if you see the serial octa over a period of time, you see the network growing here. You see the network growing here. You see the previous one. You see this one.
And finally, about 2.5 years later, the patient developed active disease in the fellow eye, for which intravitreal anti-VEGF agents were started. Aflibercept is the most acceptable or probably the best medicine to start with in such a clinical situation. So the purpose of showing this particular case is whenever you see a patient with CSCR, especially in the elderly, please look into the OCT very carefully, especially the fellow eye, and you may be having a silent macular neovascularization, and these are patients who need very regular follow-up. This is case number 2. Now, this particular patient also, if you see the color photograph, you see this RP dysfunction, and when you see the OCT, the autofluorescence, it looks like a chronic central serous chorioretinopathy. You see this particular OCT of the left eye. This patient, you can see here, is got just a serous macular detachment. But then when you carefully see the retinal pigment epithelium, you see those small elevations that come in during the period of the OCT. So this tells you that, look here, this is not just a CSCR. If you do a FFA, you see this suspicious leak here, and you see all these small areas of staining. And when you do the ICGA, you see these dilated vessels. And when you do the OCTA, you see this neovascular network. So this is actually not a central serous chorioretinopathy, but this is a CSCR-like picture with a macular neovascularization. So basically, when you are using OCTA, I think you should understand what are the various types of OCTA pictures. And I would like all of you to read this particular article, a very good article to educate you about OCTA. You should know what is this type of OCTA, where you have the central trunk, and what you have in this particular picture, where you have a very hypermature neovascular membrane, which is not going to be very active. So this particular patient was initially treated with ranibizumab. Unfortunately, ranibizumab is not a good responder for these sort of cases. And finally, the patient was shifted to aflibercept, with which he received a dry macula, and subsequently he has been under our follow-up. It's also important to understand what is defining a tolerable fluid. So once you have treated some of these patients, and once your OCTA has shown significant reduction in the smaller capillaries, and you have this dead tree appearance, and you have these sort of small residual fluids, probably you don't have to be very aggressive. So personally, I feel 3 things are important before you inject. 1 is the quantum of fluid, 2 is symptoms of the patient, and 3 is what you see in the OCTA. So the OCTA is showing a dead tree appearance, there is very minimal subretinal fluid, the visual acuity is stable, we need not be aggressive in management. This is my next case. This again is a pachychoroid neovasculopathy. You can see this membrane here, a silent one, which progressed into a neovascular membrane. The reason why I'm showing you this particular case is this patient has been under my treatment for nearly 10 years, on irregular treatment for 10 years. So when you have a type 1 neovascular membrane, it's not something that's very active. It doesn't affect our vision much. And patients retain reasonably good vision over a period of a long time. Therefore, type 1 neovascular membrane does not require that aggressive a treatment. So this is a very important take-home message. So the next is the polypoidal choroidal vasculopathy, where, as I've been describing in many meetings, that there are 2 phenotypes. One is what I call as an aneurysmal dilatation, where you have this large neovascular branching neovascular network ending in polypoidal dilatations, which is less aggressive. So these sort of patients actually, if you see this particular patient who has been under my treatment for 5 years now, he was treated initially with 3 doses of aflibercept. He achieved complete polyp closure, and subsequently, over the period of next 3 years, he has just received 3 injections. So over a period of 4 years, he has just received 5 injections. He's still doing well. He's on a PRN-based treatment, and therefore neovascular type of that is polypoidal neovascularization with a large network with less polyps responds better to treatment, does not require that much of aggressive treatment, and they will not usually present with submacular hemorrhage. So coming to the management of PCV, I still feel that PDT has a role. Combination therapy had already told us 2 things. 1 is increased rate of polyp closure. 2 is reasonably good maintenance of visual acuity. Today, the management is purely based on OCT morphology. But personally, I feel that polyp closure also is important because polyp closure gives us a long period of quiescence from the disease. So we are already present in multiple articles on combination therapy. And one of the important take-home messages that we showed is in at least half the patients who received combination therapy, at least for 24 to 36 months, they were free from treatment. That's a very important take-home message. So this is one of our old patients with a PCV. You can see here, cluster polyps, treated with one cycle of PDT in 2016. And after that, he came back with a recurrence in 2019, about 2.5 years later. Therefore, we used to get quite a long period of quiescence, and that also is a very important take-home message. And therefore, still in certain subgroups of patients with PCV, there is a role for PDT combination therapy. So coming to PCV management, this particular article is very, very important, the PLANET trial, that tells us about the role of aflibercept in PCV. This particular publication did not get much of importance when it was published, but in today's scenario, it's very, very important because it gives us three messages. One is the visual acuity maintenance was very good even after 24 months. Second is the need for injections substantially reduced in the second year. That is only 4.2 injections in the second year. Third is polyp closure was about 35%, which is probably less than the what we get in combination therapy, but better than any of the other molecules that we have today. Therefore, from that point of view, the use of aflibercept in PCV, the non-responders are only about 20%, and nearly 75% of patients with PCV do respond to aflibercept. This again is a very important article where they have shown that with good intensive treatment at 8 weekly intervals, at the end of 1 year, with aflibercept, you can achieve 50% polyp closure in polypoidal disease. Therefore, having said all that, let us look at some of the non-responders. So this is one of my patients who has been under my treatment for a couple of years now. Now he's got what I call is the cluster polyps. Now these are the most dangerous polyps because they can bleed, they are more difficult to treat, and they are very resistant to anti-VEGF treatment. Now this particular patient received monthly doses of aflibercept. Monthly dose of aflibercept with very poor response, you can see here. He was shifted to, and if I repeated the ICGA, slight reduction in the number of polyps, but still very active. Shifted to faricimab. The response was quite good. After 3 doses of faricimab, there was reasonably good response. But unfortunately, and if you see the ICGA, there is good response again. The polyp closure is there. Fortunately, the patient came back with a recurrence within 6 weeks after the last injection, and this time the recurrence was even worse. And subsequently, he has been on monthly dose of faricimab. Therefore, this is a patient who has shown poor response to anti-VEGF injections. And if you look at this particular article, they have defined the poor responders based on OCT in PCV, looking at this huge thumb-shaped or pointed PED with this you see this vacuole sign right at the roof. And if you look at this, my patient here, if you look at the first OCT, you see here, he has got a similar picture. So these are patients you can diagnose even based on OCT to tell you these are patients who are probably going to be very resistant to the management with anti-VEGF agents. So this is another patient of mine. Here you can see here, this particular patient again has got an aneurysmal type of a polypoidal disease. This is the picture. He was managed as CSCR elsewhere for quite some time, but this is not a CSCR. This is polypoidal disease. And if you see the ICG, he has got an aneurysmal dilatation. But then if you look at the response to anti-VEGF, he was initially put on Eylea, 5 doses of Eylea, but unfortunately not much response at all. And more importantly, the neovascular network was growing in spite of the anti-VEGF agents. Therefore, when you see the neovascular network growing in spite of the anti-VEGF agent, so when you start treatment, if you have OCTA, you do a baseline OCTA. And then you can repeat the OCTA after 3 or 4 injections, because that tells you what is the change in OCTA apart from the morphological changes in OCT. And this gives you a plan on the treatment. If the response is not good both ways, that means the drug is not really working. So this particular patient, in spite of multiple doses, finally was shifted to faricimab, and even faricimab did not work. Faricimab, but although the network is showing more of a mature network, fluid was quite persistent even after 5 doses of faricimab. And finally, I put him on 1 dose of brolucizumab, with which there was a dramatic response. Therefore, you can see here, there is just a mature network now, and the fluid is completely gone. So basically, someone may ask me, why did you wait so long to shift to brolucizumab? But then we look at safety and efficacy first, and safety is very important when we treat patients, and that's why there was a delay in using brolucizumab in this particular situation. Therefore, I would also like to highlight our experience with brolucizumab in the PCV. We have been using it as a rescue treatment for quite some time now, and we recently have published this particular series, or in the process of publication, of 32 patients with PCV who have shifted to rescue faricimab, and our experience has been quite encouraging because basically, most importantly, the need for injection substantially reduced, and also the response to treatment was very good, and most importantly, the response to the polypoidal PED, which is very, very important. Always I tell my fellows, look at the polypoidal PED. The polypoidal PED has to reduce in height. And if it has reduced in height significantly, then you know that there is either a polyp closure or inactivation of polyps. So that's a very important sign. And that also responds very well to brolucizumab. So having said all this, what are the take-home messages? There are different phenotypes of MNV in pachychoroid disease. We need to understand that. I have also explained the role of OCTA and ICGA, both in diagnosis and follow-up. As far as the choice of anti-VEGF agent is concerned, based on safety and efficacy, aflibercept still continues to be the drug of choice. I have no any financial interest. And when to switch, we know when to switch when there's no good response. And when we switch, I feel the best drug would be, based on current evidence, brolucizumab, and the benefits of combination therapy with vertiformin 40T, which should be kept in mind, especially in patients not responding to anti-VEGF therapy in PCV even today. Thank you.
Thank you, sir, for that extensive masterclass in managing NVAMD and the pachychoroid spectrum.
Sorry for taking 2 minutes more.
Without wasting much time, I'd like to call upon and invite my teacher from Arvind Eye Hospital, Dr. Naresh Babu sir, who is the head of vitreoretinal department at Arvind Madurai,
Sure.
for the keynote address.
Yeah. Thank you, Jyoti. Now, it was a medical retina session, but we'll be discussing a surgical complication. But anyhow, to fulfill that thing, actually, we'll be talking about the medical treatment of a surgical condition. So today we'll be talking about how we are using methotrexate in case of our surgical complication or preventing the PVR and the hemorrhage. So we all know that methotrexate is a folate antagonist. It has got a lot of indications in ophthalmology, especially in case of lymphomas, intraocular lymphomas, primary lymphomas. But we have been now using it for both regmatogenous retinal detachment as well as for the PDR cases where there is a subsilicon oil hemorrhage. The dose varies. It can range from 250 microgram to 400 microgram, and the mode also varies. We give intravitreal injection, but there are people who use the methotrexate in infusion, or somebody will fill the eyeball with the methotrexate 400 microgram, wash it and then fill it with oil. But we go for 400 microgram, 0.1 ml intravitreal injection. So we'll be discussing basically the PVR, how to prevent that in case of post-retinal detachment surgery, because PVR, that is proliferative retinopathy, is the one which causes a redetachment in most of these cases. And the chances of PVR is as high as almost 40% in case of giant retinal tear. So nobody wants a retina to redetach after its reattachment. So these are the various types of PVR. And we know the role of methotrexate in RD. So it's a very safe adjuvant. And it has reduced grossly the redetachment in case of PVR cases. So this is basically our work on methotrexate, where we have injected intravitreal methotrexate at the end of the surgery, and at the end of every week for 3 weeks we have injected. So most of the cases received 3 injections, and we divided into 2 groups, one receiving methotrexate, the control not receiving methotrexate. And in the control group, we found that the redetachment is very significantly high, but whereas in case of the cases which underwent injection, the redetachment is less. Even if there is a redetachment in case of methotrexate group, there is a very less chance of macular redetachment. So the outcome with a serial injection following cataract surgery is good. So this is our final the success rate with methotrexate. So in conclusion, it helps in the better reattachment of retinal detachment. The mean visual gain is much better in case of methotrexate group. The other thing is the methotrexate where we use extensively is in case of subsilicon hemorrhage, because most of the cases which we operate have got some sort of renal problem or a cardiac problem where they'll be on blood thinners. So in spite of achieving complete hemostasis at the end of the surgery, there will be some amount of subsiliconoid hemorrhage. Sometimes it's so massive, so that leads to severe angle closure glaucoma, sometimes PL negative eye. So we have started using this accidentally, and we found that it has got antiplatelet property also, so it helps in lysing the clot. So this is the purpose where we wanted to inject. So in all these cases, at the end of the surgery, this is a series of 44 cases. We don't have a control group after we started this. So all these cases had a subsiliconoid hemorrhage, and on POD1 where we have injected methotrexate in all these cases, again a serial injection, and we found that the vision improvement is better in this case. As I told, the dose is the same. So a few cases, this is the pre-op case. On POD18, when the patient came, this was the picture actually. Usually what we do is we go for removal of silicone oil and then we wait for the clot to lyse and re-inject oil. But this patient underwent methotrexate on 8. This is a second injection on 16th day, improving to 2/60. Third injection, improving to 3/60. So at the end of 45th day, literally the entire clot lysis, no surgery done, only with the methotrexate. This is the second case, pre-op fundus. Very good surgery, but some amount of pre-retinal hemorrhage. So with the 3 injections, the complete disappearance of the hemorrhage, no formation of membrane, no redetachment in this case. Vision stabilized at 5/60 at the end of 5th month. There's another case where you can find a traction retinal detachment. Okay, not much. So this case with the hand movements, this was when the patient visited on POD15. Hand movements, usually it is disturbing for both the surgeon as well as the patient. So after serial injections, this is the final outcome in this case. So at the end of 45th day, complete or near total resolution of the hemorrhage. But a lot of evidences are there, especially for these cases. But people have mostly used bevacizumab for this case. Very rarely people have used methotrexate. And the incidence also very high, especially in our population because of the blood thinners and other things. So we found that by using methotrexate, it reduces the rate of redetachment as well as it improves the visual acuity in these cases. So but for PVR, we have got a lot of evidences. This is the first evidence which we'll be publishing shortly for cases of subsilicon oil. The other molecule which we have started using is topotecan, which is usually used in retinoblastoma. We use a low dose that is 30 microgram. The only problem with the topotecan is it's a very expensive drug, and second thing is its shelf life is very shorter. So in case we open, we have to immediately use, and sometimes it's difficult for us to convince the patient. So we have got very few cases with topotecan, just 5 cases we have done. So we'll be comparing that with methotrexate. So this is what I wanted to say. A pre-op picture with the immediate post-op hemorrhages resolving completely. So we found that this is quite effective, especially because of its anti-proliferative as well as because of its platelet, that is clot lysing property. And a dose of 400 microgram, its safety has been established long time back when we were giving it for lymphomas. And it has got a definite role in preventing recurrent detachments. Now many people have started using it. And it also resolves rebleed as well as prevents reproliferation in case of silicone oil filled TRD cases. And we found that it really enhances both anatomical as well as the functional outcome in case of diabetic vitrectomy when we inject serially. Thank you.
Thank you, sir, for that wonderful talk. Sir.
Yes.
Check.
Naresh,
Yes, sir.
I mean, is it necessary to give 2-3 injections? I mean, with the first injection itself, you might have got the full result. Is
Sir,
it?
actually, in case of PVR, it's not going to start immediately.
Yeah.
Usually, it's going to start after 2 or 3 weeks.
Yeah.
So the first 2 injection, maybe it aids in what you call prevention.
Yeah. PVR, okay. I'm talking
Yeah.
about diabetic.
Sir, actually, every time we inject, we found that there is a gross reduction in the size of the
So
clots.
every week you inject.
Every week we inject.
Inject and then.
Yes,
at least
sir. The half-life is also very short in this intravitreal.
Yeah. Off-life. Then have you tried this? I'm asking you. We have some of these, very clean cases we do.
Yes.
And they keep coming back with you with us with this post-operative vitreous cavity hemorrhage.
Yes, sir.
We give sometimes bevacizumab, we do lavage. We don't want to inject oil because oil, the quality of vision. Suppose 6/9 vision is having unaided,
Yes.
but that fellow will keep coming. You eat. I mean, we don't know why. Everything lasered, everything okay. Very rarely we have patients like this. Now, in these sort of cases, do you think methotrexate intravitreal have any effect?
Sir,
I mean-
not only for RD, we have got elective staged surgery for TRDs. Like where the retina is good after the membrane peeling, but wherever there is bleeding, in such case, we inject methotrexate, gas, lying for a prone position for 10 days, then we call them back. In most of the cases, there is a complete lysis of clot. If needed, in such cases, we go for a silicone oil injection. Otherwise, sometimes it helps actually. But we call it a stage surgery for TRD. We don't bother about the hemorrhages happening intraoperatively. Inject methotrexate, call after 10 days, assess, then re-inject oil. But we explain the patient that it's going to be 2-stage surgery for them for even TRDs.
Sir, any experience on using it for subretinal blood in diabetic retinopathy? Some patients who have
Yes.
bleed.
No.
You
No experience. No experience.
injecting subretinal.
No, I understand. Intraoperatively.
Yes.
We have not done.
So thank you everyone for attending the session. I think we have been able to conclude well within time. If we have any questions, we'll be happy to take. I'd like to thank all Naresh Babu sir, Giridhar sir, Mahesh sir and Ashok Natraj sir for being a part of. Yes, sir. Yes.
Naresh Babu sir, you do PPV and silicone oil injection. If you find bleed there, then and there will you give an injection?
Yes.
And then repeat every week.
Exactly.
The safety profile is okay. Is it?
It's a very good safe drug actually. No issues with the safe.
Yeah, the other is with Giridhar's presentation on rolocizumab, right? Rolocizumab. He said it is very effective. So my doubt is, he said it's very effective for the pachychoroid thing.
As rescue therapy.
Yeah,
Rescue therapy
right.
services.
Yeah, I think physiologically, if you look at the pharmacological parameters show that it should work because that is a very small molecule. Is it not? And the pachychoroid is outside the RP Brooks membrane complex. So you need a really good penetrating drug. So it should naturally work better than ranibizumab. Yes. That is how in diabetic maculopathy, as he said, even if the drugs fail, you have got the option of doing surgery because that is on the retinal side. Choroidal side, you can't do any surgery.
Thank you. Thank you all.